So now I'll invite Dr. Tinku BALI. She'll be talking about, she's a veterinary surgeon, but she does a lot of cataract surgery as well. So she'll be talking about nucleus management in presence of the posterior capsular rent.
As we all know, posterior capsular rupture is one of the most feared complications of cataract surgery, but if managed right, you can have excellent visual outcomes. The first thing is not to panic, but to organize yourself. And not only yourself, but your OT staff should also be very familiar with the instrumentation needed and how to seamlessly switch between the different modes of your machine, how to switch to the vitrectomy cutter. So that is the most important thing. Now, the goals of management are firstly to avoid losing the lens, to remove all the accessible lens material, if necessary, perform a proper vitrectomy, and avoid enlarging the capsular opening and preserve capsular support. So, as in a war, and if you want to win the war, the most important thing is that stop but do not retreat. So, similarly, do not panic and withdraw the phacoprobe because a PC tear does not equal to a ruptured anterior hyaloid face. Once you reflexly withdraw the phacoprobe, you tend to rupture the anterior hyaloid face and prolapse the vitreous. So it's very important not to have hypotony and maintain a very stable anterior chamber. And to do that, what you should do is once you see a PCT happening, keep your phacoprobe inside and from the side port inject viscoelastic. Once you have a well pressurized stable chamber, that is the time when you withdraw your phacoprobe. So at no point of time should the chamber be allowed to collapse or the eye should become the eye should not be allowed to become hypotenuse. After that, you should do a thorough anterior vitrectomy. Now, to do a vitrectomy, the chamber should be a closed chamber. So, suture the main wound, make another side port, and do the vitrectomy through from your side port. Always remove the vitreous before you remove the lens fragments. Use the highest cutting rate that your machine supports and a low vacuum. You should use the cut IA mode to remove the vitreous. So here is a resident who's operating and you see how the chamber, this is the resident going in through the main port. You see the chamber is so unstable, there's so much hypotony, and the more hypotony there is, the more vitreous keeps prolapsing in front. The way to do it is like this. You see this tight, stable chamber and the cutters being used through the side port and the infusion through the other port. Another important thing is to respect the vitreous base and to avoid any vitreoretinal traction. So do not use Varna scissors or sponges to pull the vitreous because pulling the vitreous here can induce a very small tear here and you can get a retinal detachment even months after or even years after the cataract surgery. It's very common once you've had any kind of manipulation to get an RD later on. Nowadays, it is of advantage to shift to the pars plana. So you can always, talk to your vitreoretinal colleague and you can do the vitrectomy through the pars plana. This is an older video where we were using the MVR blades to make the sclerotomies. But now we have the cannulas, the 23 gauge and the 25 gauge cannulas, which are very easy to insert. So the advantage of the pars plana route is that it reduces the vitreoretinal traction. It gives you better access to the remaining lens material and you're less likely to damage the capsule once you go through the pars plana. So there are initial, there is a slight learning curve, but once you know how to do it, it's a pretty simple procedure. Nuclear management, if you have a very small phaco, a piece of nucleus, you can continue the phaco after putting in a dispersive viscoelastic. If there is a larger chunk of the nucleus, then you would have to enlarge the incision and manually remove it. And if there's a nucleus drop, of course, you'll have to refer the patient. Now, another good technique that has been talked about in recent years is the IOL scaffold technique. So once you have a PCT, once you notice the PCT and you have a few remaining nuclear fragments, you can insert the IOL. You can go behind these nuclear fragments. First of all, pressurize your chamber. Manipulate these pieces so that they are more superficial in the anterior chamber. And just forward it. So here you see the IOL being inserted. This is going in behind the nuclear fragments. And once you have your IOL in the sulcus, so then you're safe, and then you can, after that, either with phaco or manually remove these nuclear fragments that are in the anterior chamber. If soft lens matter is present in the anterior chamber, you can use the suction mode of the cutter after doing the anterior vitrectomy, and using the suction mode itself, you can remove the soft lens matter. So this is just the suction mode of the cutter, and you see how nicely the soft lens matter is removed. Now, in case the fragments dislocate posteriorly, it does become, especially if there's a full nucleus that has dropped, it is a dire complication for the cataract surgeon, but a fairly straightforward problem for the vitreoretinal surgeon. And we all know that we don't have to chase after the nuclear fragments, avoid unnecessary manipulations to prevent vitreous traction and consequent retinal detachment and CNV. So what you should do is do a thorough anterior vitrectomy, ensure that there's no vitreous in the wound. And in case you do not, if at that point you do not have the required instrumentation to do an anterior vitrectomy, then just leave it alone. Your posterior segment colleague will take care of that vitreous which is in the anterior chamber, but do not try to mess around or pull the vitreous or use varnas. Just suture the wound and leave it at that. It's also important to retain good capsular support. Now, IOL placement, you can implant an IOL even after a PCT, but make sure that it is stable. If you feel there is any doubt on the stability of the IOL, then do not implant it. And an AC IOL should always be avoided when there is a dropped nucleus, because many times when the vitreoretinal surgeon is doing that, AC IOL tends to drop back. So just a small video showing you, I will just forward it and show you. So this is the lens being implanted in the sulcus. You see there is some amount of posteriorly dislocated lens matter, but you can put in the IOL in the sulcus, and then if it's very soft lens matter, sometimes it even absorbs over a period of time. It's just the epinuclear material. So after you've inserted the IOL, then constrict the pupil and stain it with tricort. Do not put tricort before you have constricted the pupil, because most times this tricort goes behind and causes IOP elevation in the post-op period. So this is the way to do it. Once you've constricted, here any residual vitreous that is in the anterior chamber can be removed. Wound closure again is extremely important. Before referring it to the vitreoretinal surgeon, ensure that the wound is stable and the chamber is not leaky, so that there's no further prolapse. Every cataract surgeon should have an arrangement with your vitreoretinal colleague in case you ever require him. So you should both be comfortable with each other. You should be able to refer to your vitreoretinal colleague. So always have someone in mind that you can refer these patients to. The vitreoretinal surgeon, again, whenever you're referring a patient with dropped nucleus, do give the requisite information to your vitreoretinal colleague about how much lens matter would have dropped, did you do any maneuvers, whether you tried to implant a lens, whether there's a lens present there or not, and also the IOL power in case the IOL would need to be implanted after the surgery. Now, a dropped nucleus can be managed in the same sitting if you have the facilities, but it can also be deferred. And there have been so many studies which have shown that the outcome is no different even when the case is taken up as late as 2 weeks after surgery. So there's no need to panic and go in, refer the patient right away. You can wait for the corneal edema to go down, for the inflammation to subside, and the retinal colleague can operate it in any time in the first 2 weeks. So to conclude, the important points are firstly, not to panic and withdraw the probe, inject high molecular weight viscoelastic, reduce the border height, manage the nucleus appropriately, do a bimanual anterior vitrectomy, place the IOL appropriately if possible, if you feel it is stable, and most important, do not chase the nuclear fragments. So minimum, whenever there's a dropped nucleus, then minimal intervention is the best option. Simply clean up the vitreous, place an IOL if possible, suture the wound. And a vitreoretinal consultation can always resolve a dropped nucleus with minimal morbidity and excellent visual outcomes. Thank you so much.